I'm very pleased to be here today to talk to you about cancer prevention in the United States. As you've heard, unlike my esteemed colleagues, I'm not a specialist in cancer or in cardiovascular disease, but I'm a general pediatrician, and much of my work has been in public health and health policy. So this means the perspective I'd like to share with you is one of looking at the context in which decision-making occurs and how to affect that context to support broader health goals. First, because this is an international meeting, I think it's very important to take note of the current global conversation around the prevention and control of non-communicable diseases, of which cancer is a major concern. This is a diagram of the big four killers. These are of global burden of non-communicable diseases in the orange, both males and females in low, middle, and high-income countries. And the big four killers are heart disease, cancer, diabetes, and lung disease, and associated obesity. And these have been the ones that the UN has looked at really as a group. This issue of premature deaths and obviously loss of both human capital and economic development capacity has been something of note, and the estimate of over 56 million premature deaths under 60. And in the United States alone, the medical and lost productivity costs attributable to cancer in 2010 were estimated at $264 billion. So these are significant economic factors. Research that provided the evidence for this group approach to non-communicable disease prevention indicated that the common risk factors among these four major killers are in fact tobacco, exercise, diet, and alcohol. And that one of the really important interventions, aside from clinical interventions, is the challenge of creating environments in which individuals who have the correct information and wish to make the right choice, that choice is easier for them to make. And because of the increasing evidence which colleagues, especially from our cardiovascular group as well as earlier today in the cancer group, have presented, we know increasingly that health is a product of much more than health care. This is a rather iconic diagram dating back to 1991 and by Dahlgren and Whitehead, looking at the multiple factors that contribute to health and health status, age, sex, and genetic makeup, constitutional factors, race included, and ethnicity are sort of unchangeable. We can't do much about those. But as we move out along this diagram, we see a series of factors, individual risk behaviors, interactions with friends, family, relatives, and community, and obviously the broader sort of policy environment here, where society can make decisions to create healthier environments. Research by the Centers for Disease Control and Prevention in the United States have been able to quantify the relative impact of personal health care and other factors on mortality in the U.S. and found that only about 10% of avoidable mortality in the U.S. is directly related to lack of access to health care. And 20% is based on genetics, another 20% on built-in natural environment, and 50% really related to premature mortality because of risk factors, many of these exacerbated by socioeconomic conditions. So poor people, individuals in relatively deprived communities don't have the healthy choices that their wealthier colleagues have. So you need to make it easier for them to make that choice. And this evidence was really reinforced most recently by Sir Michael Marmot's Social Determinants of Health Commission, which was run by the World Health Organization. The U.S. Institute of Medicine, taking this model, has further tried to look at, to make the case for what we would call upstream strategies, early primary prevention in the broader environment, and to control NCDs, including cancer. And these would mean that you would need a partnership. Government alone can't do this. We've heard this comment from others of our colleagues, but we need to shape the environments, to shape cities, schools, workplaces, neighborhoods for prevention. The government health agencies need to work in partnership with community-based organizations, the personal care delivery system, business, media, academia, in order, and community members themselves, in order to assure the conditions for population health. The history of global health is largely one of focus on infectious disease and maternal child health, and there have been enormous public health successes in this arena globally. And the Millennium Development Goals, I think, was one of the most recent evidence of countries coming together to set collective goals on health issues. But in fact, the non-communicable diseases are not explicitly addressed in the MDGs, and as they come up for review, final review in 2015 and revision, there's a lot of interest in trying to look at how to insert attention to NCD risk factors in this conversation. There's so much concern that, in fact, the NCD discussion at the recent General Assembly in 2011 in New York was only the second time a health issue has been discussed with heads of state. The other time was in 1988 with HIV/AIDS. And so the WHO has set up a monitoring mechanism with annual reporting over the next 3 years to see how countries are moving the agenda to which they committed themselves in the fall. The case has certainly been made through a number of volumes of the evidence for the economic benefits of addressing non-communicable diseases, as well as the important social and development benefits for countries. So this has seemed to have gotten attention. You can begin to see, we had conversation yesterday about the percentage of GDP invested and why health result is not any better in the United States, and one of the reasons is this imbalance in investment strategy. To make the case for in the U.S. for health policy change, one has to usually make the economic case, because there's a huge amount of money invested in our system in the way it's currently organized. And a group in Washington called Trust for America's Health, right before the U.S. healthcare reform, did an analysis, a systematic review of return on investment that showed that for every $6 invested in proven community-based interventions, these have nothing to do with personal care, in tobacco, exercise, and diet, at an invest cost of about $10 per person per year, you begin to see all payer returns. These are the two public medical insurance systems, Medicare and Medicaid, as well as private insurance, of about $6 for every dollar invested. This is a savings of about $16 billion a year nationally. In New York City alone, in New York State alone, it's a savings of almost $7 billion a year over 5 years. These are numbers that get people's attention, and because elected officials work in 2-year, 4-year, and 6-year terms, prevention has been very hard to sell, because it was thought to be only seeing results 8 years, 10 years out, and most political people say, well, I won't be here to take credit, so why start that movement? I think we see in countries where health is a bipartisan issue, the continuity of the governance attention to health makes a big difference. So as a consequence of these kinds of analyses, the healthcare reform in the U.S. has included really unprecedented investments in prevention. So to move to cancer, this is the 1.5 million new cases a year diagnosed nationally, and it's the second leading cause of death behind cardiovascular disease. There are disparities in cancer incidence. We still have a very disproportionate death rate among African Americans in the United States. Some of this associated with poverty, others associated with other risk factors that are beginning to be better understood, but are not well understood as yet. But it's a huge issue in terms of health disparities. I want to look I want to look briefly at some of the evidence around the sort of cancer, work on cancer in two stages. One is the evidence base for individual screening, and secondly, and vaccination, and the second is the community-based activities. And the evidence base for cancer intervention at the individual level is largely developed by the National Cancer Institute, the principal federal agency for cancer research and training in the United States. NCI evaluates the evidence to determine the direction and magnitude of health effects of introducing either a clinical or community-based intervention into the general population. So they rank evidence as solid, meaning there's a level of assessment obtained from well-designed studies and, in some instances, randomized controlled trials in settings that are generalizable to larger populations. Fair evidence has sort of less higher standards, and then inadequate evidence means that for standards of proof they would not recommend the action. And so looking at those briefly, on tobacco clearly is the area where is the most solid evidence that tobacco smoking is related to lung, oral, pharynx, larynx, esophageal, bladder, kidney, pancreas, stomach, uterine and cervical cancer, and acute myeloid leukemia. And this is the cause of about 30% of cancer deaths in the United States. There's also solid evidence that smoking cessation can make a difference, even if it happens very late in life, can add life to years, and that risk factors are considerably slower after 5 years of cessation. In addition, they consider the evidence solid for the importance of counseling by a health professional and other physicians on both decreasing smoking rates and also offering smoking cessation therapies such as nicotine patch therapies, and much of this is often provided freely by public health agencies. In contrast to the strong evidence on the association of tobacco and cancer, there is less strong evidence on the influence of diet, physical activity, and alcohol. The research group NCI qualifies this relatively weaker evidence because of primarily difficulties in the studies that are needed to prove these activities. The studies seeking to isolate specific foods or nutrients may have to simplify the complexity of food and dietary patterns, dose, timing, duration of exposure, and the need for longitudinal studies often are more expensive than many experiments can support. Obviously, randomization of community trials is much more difficult to blind, and the kind of follow-up is challenging. But given those challenges, they still identify, especially through work of the NCI, American Cancer Society's nutrition and physical activity guidelines, and the World Cancer Research Fund's work on sort of epidemiological evidence on these two factors have presented some further evidence. So on obesity, these are these groups. Obesity and cancer risk, feeling that obesity is convincingly linked to postmenopausal breast cancer and other system cancers. Body fat may be a probable risk for gallbladder cancer, but no convincing evidence that weight loss can in fact reduce the risk of obesity-related cancers. On alcohol, more convincing evidence about the impact of alcohol on oral, esophageal, breast, and colorectal cancers, probable evidence on liver and in women, and the consumption of more than the recommended for Mediterranean diet health aliquots of wine seem to have an association with increased risk of other cancers. The diet issues, you get more complicated because of some of the risks described. Fruit and non-starchy vegetables probably associated with decreased risk, but vitamin and dietary supplements, no convincing proof from their perspective that these are positively associated to reduced risk. And physical activity in cancer is convincing around colorectal, some probable indications, but again, this is probably the area that's some of the weakest in terms of cancer risk reduction.